Good afternoon, everyone. We're going to give everyone just a few more minutes to get connected to audio. And then I'm going to introduce our Teach Education Grand Rounds speaker for this evening. Thank all of you for being here. We really appreciate you being a part of this conversation. It does look like we've got everybody connected, so I'll go ahead and introduce our speaker for this evening. Dr. Hetty Cunningham is the Interim Assistant Dean in the Office of Diversity and Minority Affairs. She's the Director of Equity and Justice and Curricular Affairs and co-director of the Anti-Racism Coalition. She's also director of the Narrative Medicine Portfolio Curriculum at Columbia University Vagelos College of Physicians and Surgeons. She's also an associate professor and vice chair for education and the learning environment in pediatrics at Columbia University Irving Medical Center. Dr. Cunningham partners with faculty, staff, and students across the learning spectrum to promote equity, justice, and anti-racism. Since joining the Department of Pediatrics faculty in 1998, she's worked to improve health equity at all levels, with a particular focus on curriculum and faculty development and health disparities, implicit bias, social determinants of health, race and medicine, cultural competency, communication skills, and narrative medicine for medical students, residents, and faculty. Dr. Cunningham discussed COVID-19 health disparities in the powerful 2022 documentary film produced by Oprah Winfrey, The Color of Care. She is a second-generation Harlem resident where she lives, sees patients, and teaches pediatric residents at New York Presbyterian Hospital, affiliated community-based practice. She graduated from the University of Pennsylvania School of Medicine and completed her pediatric residency at the Children's Hospital of Philadelphia in 1996. She's joining me now is Dr. Hetty Cunningham, and if we could all just say thanks a lot for being here, give her a round of applause virtually, and I'm going to go ahead and turn it over to you, Dr. Cunningham.
Terrific. It's great to be here. Nice to see you all. I think I met a number of your colleagues throughout the day today. So I'll be giving this presentation for the second time today. We had a great time at noon. So let's see, I'll just get started and share my screen. So I'm grateful to be here. I was saying earlier that I've hiked the Blue Ridge Mountains and even seen a rattlesnake there. So it's kind of fun to be connecting with you all. We don't have a lot of snakes here in New York, but we also don't have gorgeous mountains like you have down here. So it's really nice to be with you. And I want to just thank Mariah for inviting me, and for Heather and Deborah for helping set up all the details on the back end. It was a little complicated, but we got it all done, and they're so knowledgeable. I'm also excited to be here because was very inspired by meeting some of your colleagues and reading about your mission of excellence and also humanism in medicine, and talking to some of your colleagues today. We had so much to share, and I learned a lot, so that was terrific. So like I said, thank you for the introduction. Mariah said, I've been working in medical education for about 25 years now. And about 3 to 4 years ago, took on the position of Director of Equity and Justice and Curricular Affairs at the medical school, which basically I'm like the health equity thread leader. And I work with a large number of faculty and students in this work. And I'll be telling you about some of the work that we've been doing together. I also work particularly closely with 5 medical students who are Equity and Justice Fellows. And these are students who are given a stipend to help kind of reinforce and our curriculum in this area. And so a lot of what I'll be talking about, I work very closely with them on. And so that's really been a very strong program. Just going to acknowledge that so much of what I'm presenting today is really a team effort. So Drs. Devlin and our Dean Hutcherson have created some of the content I'll be presenting today. Drs. Laura Benoit and Chris Travis were students who developed a lot of the content that I'll be talking about today. And then, as I said, the fellows and the students and faculty, really a lot of people behind this work. So I'm going to start with framing the discussion. We'll talk about some inclusive teaching tools. And as I go, Heather's going to be dropping tools into the chat so that like this is really meant to be kind of, just touching on a lot of things. And then there's a lot of tools that you can go deeper into. So that's really kind of my goal here. And happy to talk further after this about this topic, which I just love talking about. We'll center on some of the anti-bias teaching curricular guidelines that we're using, and very briefly touch on curricular reform and try to have some time for questions. So I'm going to try to go a little bit more quickly than I did this morning. So what I have learned in doing this work is that framing the discussion is key to talking about systemic racism, anti-racism, and health equity. So this is a slide that we use when we're starting our conversation. Usually when I'm starting, I'm actually eliciting the norms from the group. And so that it's really an engagement and a partnership. But these are some common ones we use. What we learn leaves the room, what is said stays in the room, and everyone has different levels of familiarity when comfort when discussing race and racism. We're all here to learn. We're using this framework, the 4 ground rules of courageous conversations. This is from Glenn Singleton's work, courageousconversations.com. It's got a book, website, so you can learn a lot more, but we use this framework. So, and particularly, we talk about difficult conversations as healthcare providers. We're having difficult conversations all the time, but this is specifically when thinking about race and racism. So speak your truth, stay engaged, and we'll talk a little bit more about the reasons why people may become a little bit disengaged from this work. Accept and expect discomfort and strong feelings and strong emotions, and then accept and expect lack of consensus. And I can say that before I really started delving into how to teach this content, I had multiple experiences in my career when an issue of race and racism came up, and I didn't know how to deal with it. And it kind of just really kind of poisoned the trust and the atmosphere for this group for the rest of the semester, the year, and we couldn't recover from it. So now, I'll take this and I'll be right up front. We're gonna land in this area. The discomfort that we're gonna feel is where learning happens, and that's okay. And so predicting it is much better than kind of getting there and just being like, oh my God, what am I gonna do? So a couple of other resources that again, we'll put in the chat for you. Stephen Brookfield is someone that we've learned a lot from, and Heather's going to put his website. He has a book called Becoming a White Anti-Racist. He is an educator first and foremost, been at Teachers College, and that's where I met him. I learned so much. He says becoming a white anti-racist, but I think all of my colleagues, for whatever race or ethnicity, have learned a tremendous amount. One thing that we always talk about that he taught us was when it comes to faculty development, when it comes to teaching about racism, you can do it badly or not at all. And so that really kind of centers us in the humility required to do this work. So I guess my first topic is that you want to frame the discussion, you just don't want to jump in, because if you're jumping in with content, it can go badly frequently. This is a tool that we use with faculty, and I do student, house staff, and faculty development quite a bit. And we use this mood meter. So we're going to do this together now so that you can experience it. So when you think about talking about race, racism, or anti-oppression, how do you feel? So I'm going to ask you to identify a word for yourself, or even just a color. So, and then we're going to maybe just write down the word or the color, and then I'm going to give you a chance to write it down on the following slide anonymously. So just give you a chance to take a look at that.
And Dr. Cunningham, this is Deborah. I have posted it in the chat for our participants so that when we move to the next slide, they'll be able to see it there as well.
Oh, shucks. And I was not able to restart the Slido. Darn it. I thought I did, but I didn't. So maybe what we can do, since we're a smaller group, is maybe we'll just put it in the chat. So I'm going to use the chat instead of Slido. My apologies. So if folks could just put that color or word in the chat, that would be great. Okay, great. So we have a couple here. And some folks may be traveling or not sure, unable to access the chat. And that's okay. Okay, so we have some blue, kind of down, troubled, disheartened, some green. Yeah, so a lot of blue, kind of discouraged, pessimistic, purple, I like that, red and blue. So enraged, kind of, and disappointed. So kind of, it's really just important to be mindful of the emotions that come up. And I think also, hey, and maybe some green. Because not only are the emotions that we're feeling right now, but we can imagine what the emotions are for our learners and for our colleagues. So, if we don't kind of think about this and bring it up, we risk burning out, shying away from the topic. So, we want to be aware that discomfort is how we learn, but it can also turn us away from learning. So thank you, everyone. And my apologies if the Slido is not working. You can see here your colleagues this morning, kind of similar. So this is a tool that we use. So I've been doing a lot of bias trainings for search committees, and we use this positionality statement. So this positionality statement, also called a reflexivity statement, is used frequently in research for a research team to come together and think together about what biases they may be bringing to the research, what perspectives that may taint their view or somehow adjust their findings. So this is your worldview on the topic at hand, and how your worldview, meaning your background, your identities, your experiences, values, assumptions, might shape your perspective on the process. And just to give you an example, so this is a positionality statement that I used for one of our search committees. So this is worldview perspectives that may impact my approach to the topic of diversity, equity, inclusion, and belonging, which was the topic at hand. So I have some leadership and implicit bias, and diversity, equity, inclusion, and belonging. I'm a person of color. I'm a woman. On the other hand, I have some perspectives that may disadvantage our search for diverse candidates. I have an Ivy League bias, Northeast urban bias, and I have lifelong economic privilege. My father's a physician. So what we do is everybody writes their positionality statement. The search committee person kind of collects all that, and then they even think about that for 1 to 2 minutes before each meeting, and kind of, so that they can keep each other honest and not only celebrate the different perspectives in the room, but also just, be aware of some of the biases that might come out. This is a article that I found very, very useful. I'm not sure how many of you saw it. Wall Street Journal, Medical Education Goes Woke. And so, just very, very useful to think about how some folks in our profession, in our country, may be viewing these type of topics that I'm talking about today. And so if you haven't read it, I highly recommend reading it in order to gain a perspective. And for me, the topics that the authors and the editorial board here are mentioning, now I know what misconceptions I need to clarify when I'm doing this work. And it's really not about, being woke or saying certain words, but really about excellence in science, in healthcare, and helping our country to have the highest outcomes that we can, or the best health outcomes that we can. So I'm going to shift a little bit and talk about fostering an inclusive environment, and try to provide you with some tools in that area. So again, we're going to use the chat. And that actually might, I think that would be useful. So this is a report that came through our diversity office. And so I'm going to, let's just think about the perspectives and why this student would have reported this incident, or this comment. So I'll read it. While on my ex-clerkship, after presenting to an attending, he responded with a football analogy that I did not understand. His reply, "Oh, I'm sorry. That's right. In your country, it's the other football. Soccer, right? I had never worked with this attending. He knew nothing about me other than my name and what I looked like." So my first question to the group, which I'd like you to put in the chat, is, did this cross a line? Did this comment cross a line? And if so, what was it? Okay, this is great. So we have, yes, the preponderance seems to be saying yes, there's an assumption about otherness. So many assumptions in this response. Yes, the words "your country" reflected the attending stereotype about the student's appearance. Yes, though probably inadvertently, presumptive, maybe it was a microaggression. I suspect unintentional, yes, a little bit. Great. So my second question then is, what might the student have been feeling here, and why? So we have this general sense that maybe a line was crossed. Why did the student kind of walk all the way across campus? And this happened quite a number of years ago. So that's why we kind of feel comfortable sharing this. It's nothing recent, probably about 5 or 6 years ago. But why did the student take this to the dean? Great. So this is really a sense that, so I'll just read. So maybe microaggressions have built up, right? And I think that's such an important point. It's oftentimes, it's not the one thing, but it's, with our patients, it's not that one comment, but it's the whole history of what they've heard. Maybe felt singled out, adding to imposter syndrome. Great. Might have felt insulted, angry, sad, misunderstood, excluded. Singled out is different. Great. Aware of the power differential. Thank you. So now maybe can you talk a little bit about why the attending might have responded in this way? And I picked this vignette because I think it's something that I could see myself doing easily. And so we want to kind of think about what's going on. Great. So yeah, absolutely. I think, we just have a couple here. I'll wait for a couple more. Yes, yeah, certainly. Thinking fast, trying to diffuse the tension, like, oh my gosh. Now, I gave an analogy, it didn't work. Now I'm trying to write it, attempting to make conversation, missing the mark. Absolutely, right? And we're all, I've done this a million times, maybe not a million, but a lot, quite a lot. Maybe looking down on soccer. Okay. Yes, before I had a soccer player, that might have been me. But yeah, so definitely trying, missing the mark. And so absolutely. And you're getting all the points that that we're trying to bring out here, and similar points that were brought out earlier. And so this kind of brings us to think about, when we're talking about belonging, right? Thinking about Maslow's hierarchy of needs, right? We have physiological needs for food, water, safety, then love and belonging is right there on this list. And so our desire to conform to the standards of a group is really, really powerful. So when Maslow's talking about these physiological needs, and then belongingness also being a core need. And this need really begins with our helpless infant state and then continues throughout adulthood. And countless studies have demonstrated the primacy of belonging in human behavior and decision-making. And in fact, what some studies have shown is that being excluded from a group actually triggers activity in the same regions of the brain that are associated with physical pain. So definitely something that we want to keep in mind. So some consequences for these students who may be experiencing these threats to belonging. So there's lots of more dramatic stories that I could have, brought to bear, but I like this one because it's a real incident, and I think many of us can see us doing something like that. And in the spirit of fairness and justice, we want all our trainees to be able to learn from us. The consequences of the students, this concept of stereotype threat, I'm sure many of you are familiar with this. It, refers to the fear of confirming a negative stereotype about a respective in-group. And this fear can create a high cognitive load and reduce academic focus and performance. The effects of stereotype threat are profound and have been shown to affect students from a variety of backgrounds. For example, multiple studies have shown stereotype threat significantly reduces performance for undergraduates from less privileged socioeconomic statuses, African Americans, Latino students, women in math and science, and LGBT students from traditionally religious institutions. So we want to identify and reduce stereotype threat as much as possible to foster this inclusive learning environment. So we have fear, low self-worth that we're concerned about, confusion, disillusionment, cynicism, and burnout, none of which we're wishing on our colleagues, patients, or students. Other environmental challenges just to think about to belonging. So there's the daily professionalism issues that students are encountering, segregated care, which may be based on insurance status, but may also be cohorting people due to socioeconomic issues or racial and ethnic issues. There's mistreatment we're obviously very aware of in medical education, hazing, and then stereotype threat, as I mentioned. Okay, so we've talked about this a bit. Diversity is not the same as inclusion and belonging. And we want to really highlight the fact that particularly when we're talking about competency-based education, psychological safety is a really important part of that, framework. Students need to feel comfortable saying when they don't know something, and so we want to really focus on that. Benefits of an inclusive learning environment: increased sense of belonging, increased participation, increased performance, improved patient care, healthy students, and scientific innovation. And this is just a study by Marie Bernard, and we're putting that in the chat as well. Just from the NIH, they're really starting to bring out some of these studies where they look at the inclusiveness, the different types of people on a scientific research team, and showing that the teams that are more diverse actually have outputs that have higher impact on our profession and on science in general. So it's not just being woke, but it's really trying to develop the most innovative and useful science that we can. So what can we do to foster inclusion in our learning environments and practices? So this is another really great article, and the 2 points that I'm going to focus on are tip 2 and tip 5. So embracing a growth mindset and making a personal connection with our students, and that kind of goes back to the soccer example. When I first presented, I presented a lot of vignettes like that to a group of faculty. And one one senior faculty member and educator was in tears at the end, and he just said, I've done this so many times, this must have been so hurtful for so many of my students. And he was so kind and caring. And I had to reassure him that, this is all taking place within an environment. And when a student feels that they're being cared for and seen, these micro things, may not loom as large, and I think probably don't loom as large. And especially if the faculty member has made that personal connection, there's a lot that goes along with that. I talked to a lot of faculty members who've, made some, microaggression or slip ups, and talked to a lot of faculty groups, and really want to emphasize that, we in our profession, like, we're doing this work of relieving suffering every single day and caring for people every single day. And it's not that, we need to change what we're doing. It's not that we're not doing it really well. It's just, these are some tips that maybe we can, do things even better and help to bring along our trainees even a little bit more. So this is a website, and we'll put that in the chat as well, that we created at VPNS. And again, this was a student-led project. And so this is called Promoting a Bias-Free Curriculum. There's a learning environment reporting portal where students can put in anonymous comments about bias they see in the curriculum. And I just want to emphasize that the way this was set up was to be a partnership. So students could put in positive examples. They can put examples for feedback where they feel the faculty member could shift what they're doing. But it's nobody gets in trouble for this. We have a conversation, and it's really supposed to be a learning tool for everybody. So really emphasizing that lifelong learning and that supportive environment that we're really trying to promote. So I'm going to go through the guidelines one by one with some examples. So the social construction of race runs through all of these. So being mindful of language, attitudes, and behaviors, being inclusive in representations of healthy, normal, being inclusive in representations of pathology, avoiding stereotypes and representations of pathology, exploring structural reasons for differences in health outcomes, and acknowledging the limitations of research. And I'm going to go through each of those now. So when we talk about the social construction of race, I just want to take a moment to look at this slide. Anything that somebody notices about this slide. So schizophrenia described in all races and geographic areas, incidence and prevalence vary throughout the world, male to female ratio 1 to 1.4. With regard to the topic of this talk, thoughts that you might have. This is, here we go. Yes, only binary sex identifiers. Thank you so much, Heather. Race is a social construct. How do they measure it? Thank you so much. So exactly. The point that I'm trying to make here is exactly the point that you put in the chat there. How are you measuring race? What is race and why is it here? So it seems like what this slide is saying is that schizophrenia is found in all people. And when we put a slide like this in front of our students, we are inadvertently saying they may be taking away the concept that there's something scientific or biologic to race, right? Because we're not saying how we're defining it, and we're not saying why we're putting it on this slide. So either you're saying, genetically, so there's something, that has to do with racial background, or you're saying it's a socioeconomic, it's very, what is the student supposed to take from that? So every time we put the mention of race in our slides, we need to be saying, why are we using it? What's the scientific import of that statement? So that's a very common concept. And we'll put another link in the chat. This is from a video called Race, the Power of an Illusion. I think the power, at least for me, to start, even when I started doing this work, to untangle race versus genes is very complicated, even though we're scientists. And we probably should know this backwards and forwards, from when we were in medical school, but this was never taught. So this idea that the phenotype is somehow, the color of your skin is somehow encoding the rest of your health or your DNA is so powerful. And so this is something that we have to start to detangle, and it's complicated. So this is a nice, if you're trying to do this, it's a nice video. So being mindful of language, attitudes, and behaviors, eliminating the use of outdated and imprecise terms. For example, Oriental, describe an Asian person, Caucasian to describe a white person. I have to say that in the first iteration of this guide, we had Caucasian in there, and we've now changed it, but to mirror the census and the NIH recommendations. But just to show you that this is an evolving words that we use. Using person first language. This is a concept that came in the 70s from the disability advocacy group. So if you want to read more about Guide to Language, Narrative, and Concepts, the AMA and AMC has this tremendous guide. And so we'll put that in the chat. But the main message that they're bringing out here is that, we want to help and be advocates for health justice. And the argument that they're making, and I think very elegantly, is that our words and our words can be an instrument to changing the culture. So we start with maybe using person first language, and then these words are building the stories that we share. And then finally, our deeply held cultural values will shift over time and have shifted over time already. So it's 53 pages. The first probably 5 pages is all you really need, but then if you really want to get into it, you can read the whole thing. I found this very, very useful. To thinking also about we're like, oh my gosh, why do we have to use these new words? And, when you read this, it's kind of like, it makes sense. These are the small things that we can do to help more people feel included in our system. So it's really about shifting the narrative gradually and in an important way. The CDC also has guidelines for inclusive communication, and we'll put that in the chat as well. So speaking of words, one of the ways that we as healthcare providers communicate is through chart notes. And so we're going to talk a little bit now about how we might be transmitting bias in our language that we use in our notes. And this is going to be, so I'm going to read this vignette. This is from a wonderful article called Do Words Matter by Gadou et al. In 2017. And this is taken directly from their article. So I'm going to read this note, and then I'm going to ask the group to put in the chat examples of stigmatizing language that you hear. So Mr. R is a 28-year-old sickle cell patient with chronic left hip osteomyelitis who comes to the ED stating that he has 10 out of 10 pain, quote, all up in my arms and legs, end quote. He is narcotic dependent and is in our ED frequently. At home, he reportedly takes 100 milligrams of OxyContin BID and oxycodone 5 milligrams for breakthrough pain. Over the past few days, he says that he has taken 2 tablets every 4 to 6 hours. About 3 months ago, patient states that the housing authority moved him to a new neighborhood, and he now has to wheel himself in a manual wheelchair up 3 blocks from the bus stop. Yesterday afternoon, he was hanging out with friends outside McDonald's, where he wheeled himself around more than usual and got dehydrated due to the heat. He believes that this, along with some stressful situations, quote unquote, has precipitated his current crisis. Pain is aching in quality, severe, 10 out of 10, and has not been helped by any of the narcotic medications he says he's already taken. On physical exam, he appears to be in distress. He has no fever. His pulse ox is 96% on room air, and the rest of his physical exam is normal, although he reports tenderness to palpation on the left hip. So if people can go ahead and just, what do you see? Are there any areas of stigmatizing language that you notice. Great. So we have description of the patient. So sickle cell patient rather than patient with sickle cell disease. Exactly right. So we're not using the person first language here. And I have to say, one of the things that's been most impactful for me, even in my personal life, is this idea of the idea of person first language. I've started to think of people in my family differently, because I'll think of them, not in person first language. And it's changed my relationship with them. So I mentioned the housing authority, hanging outside McDonald's, great. And then narcotic dependent in our ED frequently, putting stressful situations in quotes. Exactly, all these things. So I'll go to the next slide, and we had some, so I'll just say what you already said, right? So one, we're casting doubt on the validity of the patient's experience by using quotation marks, as was mentioned. Patient reports, he claims, he states, he appears to be in distress, right? Equating a patient with their disease, blaming a patient for their symptoms, narcotic dependent, NRED frequently, perpetuating negative stereotypes, as someone mentioned, hanging out with friends, mentioning the housing authority. Is that really relevant here? Maybe it's relevant, but it might go in the social history, right? And then use of quotations to bracket dialect or vernacular English, right? So pain all up in my arms and legs. This is, Black vernacular English, which the writer may A, be unfamiliar with, or B, may subtly be looking down on, right? So I'll just read the neutral version here. And these are all the things that you mentioned, right? So Mr. R is a 28-year-old man with sickle cell disease and chronic left hip osteomyelitis who comes to the ED with 10 out of 10 pain in his arms and legs. He has about 8 to 10 pain crises per year, for which he typically required opioid pain medication in the ED. At home, he takes 100 milligrams of OxyContin BID and oxycodone 5 milligrams for breakthrough pain. Over the past few days, he has taken 2 tablets every 4 to 6 hours. About 3 months ago, he moved to a new apartment and now has to wheel himself in a manual wheelchair up 3 blocks from the bus stop. He spent yesterday afternoon with friends and wheeled himself around more than usual, which caused dehydration due to the heat. He believes that this, along with recent stress, precipitated his current crisis. The pain is aching in quality, severe, and not alleviated by his home pain medication regimen. On physical exam, he isn't obvious distress. So thank you all for that. So the second is the second issue on the curriculum is being inclusive of representations of healthy and normal. And this came up because the medical students were in anatomy and they were taught, the slide on the left was shown, and they were taught that healthy gums are pink. And they knew that, many of them themselves and their family did not have this kind of pink gums, but they may have had pigmented brown pigmentation in their gums. That kind of is what got them started. And now there's, this is the slide on the right is the one that's shown in their anatomy class. B3 is being inclusive in representations of pathology. And I could say that, I have been a pediatrician for 30 years and never once did I think about the APGAR score and how, we're being taught to rate, the pinkness. And I was never taught how to discern cyanosis on dark skin. So how are we teaching our residents how to take care of this little boy when he comes out? Hyperbilirubinemia, another one. I actually went back to my slides, and even though I'm someone who has thought about race my entire life, all of my slides in my teaching bank before I met 5 years ago when the students started this were on white skin. And I think that every photo that I saw in my training was also on white skin. So when I went to look up measles, how am I going to show my residents how to identify measles? If you Google, you're going to get all of these photos on the left, and it's very, very hard to get this little guy on the right, who is going to, more likely be the child who's going to present in my practice in Upper Manhattan. So where can we go to learn more about making a diagnosis on skin of color? So visual diagnosis is a plugin in UpToDate. Here you can see you put in discoid lupus, and then you have to scroll down a little bit and you can see images of discoid lupus in Visual DX. And then you're going to pull up these images, and you can see here that you have all skin types, and then you have skin of color. So that's a really powerful tool. We're going to put in the chat, and also there's a resource guide that I'll share with you that has a number of textbooks. There's the website brownskinmatters.com, and these skin of color YouTube videos I highly recommend. I learned a lot about caring for skin of color with these videos, and they're also on the resource list, and this is a nice drawing. So number 4 is avoiding stereotypes and representations of pathology. So the examples might be only showing cases of men who have sex with men and young people with STDs, or maybe only people of color with trauma. This is another tool that you can use. And again, we'll share all these slides with you. Actually, I didn't mention that before, but should have. This is a website here, redcapupstate.edu. This is the upstate bias checklist. So you can put in your cases and get recommendations for how to eliminate bias in your case teaching. So that's a really powerful tool. The 5th is exploring structural reasons for differences in health outcomes. This is a slide from the CDC. So let's say you're presenting COVID cases, hospitalizations, and deaths by race and ethnicity, and you only present the top part here. So you tell your students, well, these are the rates in these different racial groups. But now the CDC is including this bar down here, which says that race and ethnicity are risk markers for other underlying conditions that affect health, including socioeconomic status, access to healthcare, and exposure to the virus related to occupation, e.g., frontline, essential, and critical infrastructure workers. And just to put a plug for that movie, The Color of Care, which is really a memorial to the frontline workers that we lost due to COVID-19. So just, really being mindful when we're presenting these disparities data to cue our students into the underlying conditions that may be undergirding these statistics. This is a really nice article that I highly recommend, which looks at 400 clinical practice guidelines in pediatrics and talks about how race is portrayed. So these are guidelines that we use every day, that I use very frequently. And the conclusion of this article was that race is frequently used in ways that could negatively affect healthcare inequities. So some of the ways that this may happen is normalizing the majority group, in other words, centering whiteness, conflating race as a biological risk factor is the most common, conflating race with a negative stereotype, conflating race, ethnicity, and genetic risk. That goes back to the race, the power of illusion, and then establishing testing or treating thresholds or using racial coefficients. And I think finally is acknowledging the limitations of research when we're presenting research to our students. So examples might be underrepresentation of minoritized groups in the research, and then confusion of categories, very, very common. And confusion of race and gender is similarly extremely common. I was just talking to a faculty member, and the students noted and gave feedback in our portal that the faculty member was using Blacks and African Americans interchangeably. And when we went back and talked to the faculty member, it turned out that the article had actually used African American, and then Black was put on the slide. And this was in a lecture about precision medicine and cancer care. So the students, understandably are like, where's the precision? We need to really know what population we're talking about. So it's been helpful to get that feedback and to be talking more and more of that. When we first rolled out these guidelines in 2017, we did some follow-up in 2020. It seemed like the use of the guidelines was fairly low. So in response, we created this slide, and this slide is now all of our preclinical lecturers have this slide at the beginning, and it's called Statement of Partnership and Humility. In the service of increasing equity at VPNS, I, the lecturer, have considered the VPNS guidelines for promoting anti-bias inclusive curriculum and creating this lecture. I invite your feedback. So there's the lifelong learning that's being modeled by the faculty member. Very, very important. And if you have suggestions for me, you can email me. So that's not anonymous, or you can enter anonymous feedback in the portal. And so just the number of engaged, supportive, and helpful feedback that we've gotten from the students is really heartening. Just in terms of the curriculum, we're going to put in the chat. So we developed some anti-racism learning objectives modeled off of the AAMC guide that we'll put in the chat there. I think the main thing to say about that is that when we're thinking about equity and justice curriculum, we want to use this spiral model, so that in preclinical, we introduce a concept, we reinforce it in clinical, and then we reinforce it further in the fourth year. So for example, recognizing biases. So preclinical, you understand the concept of a bias, you reflect on your personal bias, you have some knowledge about the research on bias. Clinical, you demonstrate some awareness of your own personal bias in clinical care. And then fourth year, now you're strategizing, how can I think about minimizing these effects in myself, others, and structurally. This is just, I found out that pulse oximeters were thrown off by dark skin from my son, who's 24. He looked on Instagram and said, "Mom, did you know about this?" Never learned about that in medical school. So just ways in which, we're growing, learning from the young people often, and some gaps in our own education. And I'll be happy to take questions. Thank you.
And feel free to unmute or to post any questions in the chat that you have for Dr. Cunningham. Dr. Schlimmer, it looks like you're unmuted.
I did. I was reflecting on what you said, Hattie, and the subtleties that are incorporated in anything we do. I was thinking about that description of a patient. Obviously, there were a number of subtleties that were almost evident bias, but a lot of it are very subtle things. It's going to take a lot of time and a lot of introspection for people to overcome this personally. And that's why I use the word, pardon me, disheartened. And when I chose the color and a word, because I don't see our society generally as prepared to deal with this. And we have these fools in politics who are so counter. I want to say to people, if you're not woke, you're not Christian, or you don't have any religion.
I do find the political scene disheartening, but I can tell you that I don't find my local circumstances and the people that I've talked to around the country in medicine, I find that very heartening, because our community, our medical community, is able to see, and oftentimes, I'll get the report of the feedback. We don't like to call it a report, and I'm the one who takes all of that feedback and I take it to the faculty, and it's just wonderful. A lot of times, immediately there'll be defensive,ness, and then as we, it's clear this is not a court of law. Nobody's in trouble here. This is a conversation. And there's one particular faculty member I'm thinking of, at first he was like, "Oh, why do we have to do this?" And then he emailed me a couple of weeks later. He's like, "I was talking to a reporter. She used the wrong word. I corrected her," So I think we're coming along. And I think, politicians ideally, won't be telling us how to do our job. Like, we're the scientists here. And so we need to, we're the experts. And hopefully we'll be able to maintain some autonomy. But I'm heartened within our
I understand.
education. Yeah.
Thank you very much. Very nice, insightful.
And Dean Lehrman has made a comment in the chat, and he says, thank you, Dr. Cunningham, for the engaging and informative session, chock full of great resources and perspectives. You energized my green mood toward yellow. Thank you, Dean Lehrman, for sharing that.
And I just have to say, we are all in this together. We need to take one step forward together and keep moving. That's how we get where we need to go, one step after the other. Because when we look at the distance we need to travel, it can be disparaging. But we think about the community we can form and taking each step, it can be, it gives me optimism.
Yeah.
Thank you.
I feel like we've come a long way already. And we have to just keep fighting forward. Yeah.
Any other comments or questions before we wrap up here this evening?
It's great to see your optimism. So thank you.
It's always a good end to the day and to the work days to end on an optimistic note. I think that's important. So
Great. Well, thank you. It's wonderful to meet all of you all. Thanks for your contributions. And I'm energized.
Thank you so much, Dr. Cunningham, for giving us so much of your time today. We greatly appreciate it. And if no other questions, we will wrap things up for the day. Thank you guys for being here this evening. We really appreciate it. Deb and Heather have both been diligently posting things in the chat, both the evaluation for today's session and lots of resources. And as we mentioned, we will make sure to share all of these with all of our attendees today and collate them in a way that you can find what you're looking for. So thank you all for being here this evening. We hope you have a wonderful rest of the day and stay optimistic. Bye all. Have a wonderful evening.
Bye.